there's quite a few people here. Let's get started. So, hey everyone, welcome to the Respiratory Physiology session 2. So we might just get started. So I think I've sent the objectives through, so we'll just crack on and again, just try to keep this exam focused, ask lots of questions and write up lots of stuff. Now, I'll give everyone a second just to think about this question. So actually, just to go through today's objectives: lung volumes, capacities, dead space, composition of ideal alveoli and mixed expired gases, oxygen cascade, alveolar exchange of oxygen and carbon dioxide, diffusion capacity, its measurement, and normal VQ matching. So we'll go through those today. Now, just to start off, so I'm going to ask someone about lung volumes, capacities, and the measurement of normal values. Has anyone studied this recently, or anyone want to have a go at this? Always love to get put on the spot.
Yes, I have studied this very recently.
Hey, so here we go, brave soul. Okay, Mason, let's and obviously, everyone's in their own rooms on mute. I want you guys to practice just saying it out loud as well, because this is one of the, I guess, the pretty common questions you might get. So let's start with this. So actually, Mason, do you have a piece of paper? And are you able to?
I do. I've also got an electronic pen, and I can potentially draw on your slides.
Yeah, draw around the right side of the screen.
Yeah, let me just change it to my other monitor. Cool. All right. So hold on, let me just turn this into my laptop into a tablet. Sorry that you might be looking at my nose very briefly.
Oh, nice.
Oh, thank you for giving me some space.
Wow, my writing's so good. Mason, this is actually about the same as my writing with a pen, so you can get started anytime. I'm doing nothing important here.
Cool, no worries. Total. Now, I'm taking some shortcuts given how dodgy this is to draw. So the numbers on the right-hand side are the milliliters per kilogram, approximately for each of your inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume.
Yep.
Then in terms of the relevant capacities, which are made up of 2 or more volumes.
Yep.
So your functional residual capacity is made up of your expiratory reserve and residual volume.
Actually, Mason, I'm going to get you to draw it on a graph, actually, if you're able to.
Yeah, sure. I'll steal the bottom of this space. So if this is our tidal volumes going in and out, if we're then expiring all the way to residual volume and then inspiring all the way to inspiratory reserve and then returning to tidal volumes. So
and Mason, just with that, it's funny because none of the diagrams show a full expiration as the first thing. So just as a matter of tradition, I'm going to get you to go inspiration to, total lung capacity or vital capacity breath first, and then full expiration.
Yeah, sure. Okay, sure. So hold on, let me go back to draw. Cool. Okay. So initial tidal volume breath, inspiration to total lung capacity, then expiration to residual volume, and then return. So then if I were to change some colors around, so that's my tidal volume in between this space. Down the bottom, I've got this line indicates my residual volume, and the space between the two. So this is my FRC at that line. And then let me see if I can go all the way to the left. So this here is total lung capacity, but then eliminating the residual volume capacity. Sorry, that's my vital capacity.
Yep, sounds good.
And then that's the base, and then total lung capacity is down here.
Yeah, fantastic. Now, and so when you get asked this question, it's just very easy to draw a graph and demonstrate each of the numbers. And I like that you gave some numbers there. What were the units again?
Yeah, so that's mils per kilogram
Yes,
of body weight.
Beautiful.
And so, approximately tidal volumes of 7 mils per kilogram, in a 70 kilogram adult comes to around about 2,100 mils.
Sounds good.
But again, very dependent on, that's for FRC, ends up coming to, it depends on body position, of course.
Yeah, of course. Okay, I'm just going to clear all of that. Good. So mils per kilo. What instrument do you use for that, by the way?
That assessment there could be measured using a spirometer,
Yep.
particularly noting that the residual volume was not able to be detected using the spirometer.
Yep, sounds good. Any other instruments that you could use?
To detect your those various measurements,
Yep.
I can tell you some measurements that would include residual volume and FRC.
Just to do that graph that you did, any other instruments that could do it?
I'm not sure, sorry.
No, that's right. So like the common thing that they talk about is the Benedict Roth spirometer. So, spirometer, that's great. But you could also use any kind of flow meter. So I think the Vitalograph or the right respirometer can also do this kind of stuff. And you've described what the subject does, which is good. So as you're drawing it, I like that you describe what the subject does, take a vital capacity, breathe in normal tidal volumes, take a vital capacity breath, then exhale all the way down to residual volume and then resume vital capacity breaths. And that graph, I just found it really easy then to, describe and put down each of your types of volumes and capacities on that graph as well. So what can't you measure again? You already mentioned it.
Yeah, so unable to measure residual volume and therefore any capacities which contain residual volume, such as total lung capacity and FRC.
Excellent answer. So how do you measure these then?
So there are a couple of different techniques which are available. The first which I would discuss is the helium dilution technique.
Mm-hmm.
So this involves a patient inspiring for a period of time from a reservoir of a known concentration of helium.
Actually, I'm going to get to that in a second. So helium dilution, what's the other?
So the alternative is using Plathismography or the body box technique.
Yeah, sounds good. So just to show, you didn't have so much space, Mason, so it's all good. If you get asked this in the exam, you want to treat it like a normal graph. Take up a lot of space, draw potentially time on the x-axis, volume on the y-axis, with the right volume, and just roughly get approximately the right volumes, because it seems like when I was going through this, examiners would always want to ask you the absolute number in an average person. So just having 2.5 here and 3 there and maybe 5 as your total lung capacity, it's approximately right, and it just helps you to graphically show where you are and move through the viva quickly. Okay, so who wants to describe? Actually, I do feel like everyone should have a go at this. So we've got the helium dilution method. I want you guys to, I'll just give you a quick flash of that. I want you guys to describe what it is, maybe write down the equations, knowing whatever you know, and then I'll ask someone who's, I'll ask someone who's keen at the end of maybe a minute or so. Take a minute, explain the helium dilution method to yourself, and then I'll ask someone. Yeah, go for it, Dee.
So first of all, the helium dilution method works on a principle of the formula C1 times V1. So concentration 1 times volume 1 equals concentration 2 times volume 1 plus volume 2 in brackets. Mm-hmm. Oh yeah, like you got down there. And that works on the law of the conservation of mass. Mm-hmm. And the way you do the technique is that you, as Mason said before, you inhale a known concentration of helium, mm-hmm. And then you sort of give it a bit of time to equilibrate. I'm not sure how long. And then you exhale at the end of a normal tidal expiration. They will measure the concentration and the volume. So concentration of helium within the spirometer as well as the new volume. And so that way you only have one unknown in the equation, which would be V2. Yep. And that would equate to your functional residual capacity.
Great, and that's really good explanation. I mean, I like the fact that you kind of mentioned the procedure for it. You mentioned exactly what the patient does, and then you mentioned the equation. You mentioned which value in that equation. We get so many equations that they don't exactly specify which is FRC, but everyone should know that the second volume here, that's obviously FRC after the patient's exhaled a tidal volume breath. So that's the FRC that's remaining. And yeah, then you mentioned the law as well. So yeah, that's a good explanation. And it would seem that this is the one you want to get if you want to explain any of the, either helium dilution or body pleth. So which value is FRC? You explained. What's the final equation? Hey, Dee, just do you want to rearrange that equation for me?
Yeah, sure. Well, I can't do fancy drawing like Mason's. I'm going to do it on a piece of paper.
No, that's right.
Yeah. I've got basically C1 V1 divided by V2 minus V1. You can always take V1 out of the equation. And
so
then
C1 V1 divided by C2 and then take away. That's right.
Oh, no, sorry. I was just rearranging like normal. Sorry. Is that right?
That's right. You probably got V2 equals C1 V1 over C2 take away V1.
Yeah.
Now, interestingly, what does West have? West has V2 equals V1 times C1 take away C2 over C2. Have you guys seen that equation?
I guess you could do that too. You just have to take V1 out and rearrange it.
Yeah, exactly. They're exactly the same. When you rearrange this equation, just the most simple way of rearranging, which is, divide by C2 and then have a minus V1 there. That comes basically as the top equation here. But then I think the technical equation where, you got your concentrations together, that these are the things that you measure, and volume 1 is something you measure. This is the way that I guess if they did in a respiratory lab, this is how they would rearrange it. But yeah, the equation's exactly the same. Who wants to tell me about body plethysmography?
So essentially, this is when a patient sits in an airtight box, there you go, and they're breathing through piping, which extends out of the box, where the person conducting the experiment can close a valve that is in line with the patient's airway, so that they're then breathing against a closed airway, with the idea being that their attempt to inspire as their chest wall expands is increasing the pressure inside the box, and that change in pressure can be used to calculate a change in volume. So it works off of Boyle's law.
And that's good. Like, if you were just to say what you said then, I feel like that's a pass. You've explained the principles well. And I just don't think this is an exam of mathematical ability necessarily and, complex formulas. So just to know that, that's a good explanation. You've mentioned what occurs, a patient sitting in a box, they inspire against a closed valve. You can measure volume and pressure, and you can measure that change or the increase in pressure in the box and the decrease in pressure in the person, and therefore you can find FRC through that system there. So that's Boyle's law, did you say?
Yeah, so Boyle's law is, similar to the law that Dee described, but rather than concentration, now it's pressure. So it's pressure 1 times volume 1 equals pressure 2 times volume 2.
Yep, that's it.
Whereas in this scenario, volume 2, we're saying is, I think you have to think of it separately as the pressure and volume of the patient and of the box.
Yeah.
But volume 2 is essentially your starting volume, and then plus or minus the change in volume, if you're talking about the increase in volume in the patient or the decrease in volume in the box.
Yeah. Hey, so can you do the equations?
Box is pressure 1 times volume 1.
Yeah.
Equals pressure 2, and then I would say like times volume 2, where volume 2 is volume 1 minus inspiratory volume or change in volume.
Yep, take away. So V1 take away V2, or yeah, let's call it change in V.
Yeah.
Wow, that's terrible. Sorry, guys. And so, and that's useful because now I've got a box equation.
Yeah. And then for the patient, it's their airway pressure. So another pressure against a pressure 3, multiplied by their FRC is their starting volume.
Yeah, good. So that's often described as V2, but just know that V2 now is FRC equals?
Equals another, the patient's second pressure, so pressure 4.
Yep.
Multiplied by volume 2 or FRC, plus the change in volume. So the volume has increased in the patient as they expire. So it's a positive in that equation, but it's a negative in the box equation because it's decreased the box volume.
La, is it necessary to extend these equations much further than what you've described here?
I don't think so, because this equation in itself, I feel like this is all I'll need really, because I measure the box pressure initially. I know the volume initially. So I'll have 2 values there that will give me a number. If I was doing this in a lab, pressure 2, again, measured. I've got that number, nothing else to do there. V1 I already knew, and then minus the volume. So that would be, that could be solvable because it's just one equation. So that's easy. And then the patient, again, I've got a measure of P3. I don't know V2. I know P4. I know the change in volume because I got this change in volume from this equation here. So now I've only got this one unknown, which I can solve for. So to answer the question, it would make no sense to me to extend this more than what I've described there.
The main reason I ask is, I think Mason and I were talking about this offline, and we were trying to decide essentially what is the V1 box volume, because according to Boyle's law, it's a gas law. So really it only applies to the gas inside the box. So therefore it's actually only the volume of the box minus the volume of the patient. And then you get to the next question: how do you measure the volume of the patient so that you get the dimensions of the box? And if you look at various texts, I think that that Maggie and Tully measures their volume by using a syringe apparatus at the end of the box, and that they aspirate and or inject air to normalize the pressure, and the volume of air that they introduce or remove from the box is equal to the delta V, and that's their simplified sort of explanation as to how delta V is calculated. Alternatively, you can do like a simultaneous solve of both of these equations, but then you do need to know the volume of air inside the box that does not include the volume of the patient. So then it all got quite complex. So we thought, is that enough? Just
I think definitely this is enough.
Okay.
I would be I feel like they probably won't even ask you this. They'll just go, great, double application Boyle's law. I think that's where they'll stop it. But yeah, I think that's a really good point that you raise. And obviously, when you're in a respiratory lab, they've got whatever system to take away your volume. But yeah, I love the idea of people just asking me questions and just making up answers on the fly. So you have a box of a known volume because you can measure it. And I think what you're saying is, how do you know the volume of the patient that's going to displace the air? Is that?
Well, I mean, you could submerge them in water and figure out, the height of water rise or something, and you can measure
Yeah. And I guess is the thought that, when the patient's lungs expand, we're saying that the box gas is being compressed, but are we also saying that all other parts of the human being sitting in the box are being compressed as if they were made of gas? Or when we say box volume, is that the volume of the container before the patient hopped in minus the volume of the patient?
I think because, I actually don't know the answer, but the way I see it, because it's, any increase in pressure of these substances won't affect the solid substances within. Therefore, it won't matter that much. But I do get the feeling that if we, this won't be useful for the exam anyway. It'll be very academic, and if you know this as it is, it'll be absolutely fine.
Cool, thank you.
That's great. That's great that you went down that rabbit hole, though.
I reached out to Luke, who's the usual answerer of my peculiar questions, and we both got stuck.
Yeah, nice. Good. So from here, yeah. So body plug measures something that helium dilution doesn't. What's that?
Collapsed airway volumes.
Yeah, sounds good. Okay. So that's essentially FRC and measurement and lung volumes. So let's get on to this. Yeah, just take 5 minutes. Just get pen on paper, do an SAQ, and I'll give you time now. Get your usual structures, get a definition out, normal values, how you measure it, functions, and the factors affecting it. Like, get a complete answer, make as brief as possible, write it down in 5 minutes, and yeah, time starts now.
So FRC, my definitions were it's the volume of air left in the lungs at the end of tidal expiration.
Mm-hmm.
It's also the point of equilibrium of elastic recoil between the lung and the chest wall. And it's the lung volume at which compliance is maximal. And it's composed of residual volume plus expiratory reserve volume.
Yeah, sounds good. Keep going.
Normal values are 30 mils per kilo. It's made up of residual volume and expiratory reserve volume, which are both 15 mils per kilo each. So about 2,100 mils in a 70 kilo person. It can be measured using the helium dilution or body plathismography techniques, which we've just spoken about. And in terms of functions, it's a store of oxygen during apnea, such as during induction of anaesthesia. It maximizes compliance and also minimizes pulmonary vascular resistance and airways resistance at that lung volume, prevents atelectasis, and acts as a buffer of oxygen during normal breathing to maintain constant arterial PaO2.
That's great. And that's a bit of a list of stuff, and obviously you got those right. Do you have a way of remembering all that?
No, not really. Just thinking of its oxygen roles and then the consequences of where it is in terms of being on that steep part of the compliance curve and what that means.
Yeah, sounds good. Keep going.
And then factors affecting it. So thinking of factors increasing and decreasing it. So factors increasing FRC, things like emphysema and normal aging, which is due to that loss of elastic recoil of the lungs or destruction of tissue. And then factors decreasing it's often due to mass effects. So things such as pregnancy and obesity will decrease your FRC. And then things that reduce your muscle tone as well. So like anaesthesia and positioning also affects it. So it's maximal when you're erect and then it reduces when you're lying down supine by about 30%, 20 to 30%.
Okay. I like that you went through the things that increase and decrease it. Essentially what I've just done, most things are just affected, I guess. But yeah, I've said chest wall as one of my headings, and that's like diaphragm, so pregnancy, abdominal mass, posture, anesthesia, and expiratory tone, and then burns and kyphosis, then lung factors, compliance factors, which are a whole bunch of things that I think we've already gone through, emphysema, pulmonary edema, ARDS, and airways resistance can cause dynamic hyperinflation. So I've just added that. And then I've added kind of the PEEP effect as well. Yeah, so as we mentioned, just as a structure, and you did this, the fact that you said, and you're always mentioning anesthesia and always mentioning patient comorbidities, because that's just a way to hopefully get some extra marks, because you're thinking broadly and it's easy enough to say. That's really good.